Welcome again, and we're going to talk about HRCT lung and diffuse lung diseases, predominantly focusing on interstitial lung diseases. Please look at this image and in your mind try to make a diagnosis. Try and see whether you think this is any of those diagnoses that is listed on the left based upon the pattern that we see on this particular image. I assume you've done that. Now let's try and figure out what's happening. That image is a blurred expiratory image, but this is the kind of image that is produced by about 70% of all scans done for diffuse lung diseases in our country on any one day. What we need is this kind of an image. This is the image in end inspiration. It's not blurred. It tells us that there is no ground glass the way we are seeing it on the image on the left. Yes, there are likely areas of air trapping because we see that on the image on the left is expiratory, and therefore we can pick that up as well. But the kind of image that we require is the image on the right. It's not difficult to obtain this. It is not machine dependent. It is person dependent, and we need to make the effort to tell the patient. So, have a protocol where somebody can sit with the patient and tell the patient to take a deep breath and hold it so that we can get the quality that we require. So, before we start interpreting HRCT images or looking at diffuse lung diseases, it is extremely important to have a good quality study. And what does that mean? It means breath hold, full inspiration. You will need an expiratory set, so even more reason to train the patients. 1 millimeter slices that all CT scanners have today, and in very select cases we need to have prone images. So let's look at the various ILDs that we have. And if you look at what Dr. Poletti did, is he put them into 5 buckets. You have exposure related, which is obvious, then all the CTDs, then we have sarcoid with its own bucket because it's such a great mimic. Then we have the idiopathic interstitial pneumonias, and then we have the miscellaneous group that remain miscellaneous at this time because we don't know enough about these conditions, but hopefully at some point in the future they will move into one of the other buckets. So, if we come to the idiopathic bucket, we have 6 major and 2 rare conditions. The 2 rare conditions are LIP and idiopathic pleuroparenchymal fibroelastosis that are really rare. Even in a busy practice, to see LIP is extremely unusual, and that too typically occurs in the presence of either Sjogren's disease or an HIV positive situation. And we need to be really careful before offering any of these rare diagnoses. And in all humility, we know that there are some patients where even after a multidisciplinary meeting, we may not be able to arrive at a diagnosis, and we call them unclassifiable. But otherwise, we have the 6 major idiopathic interstitial pneumonias that have their acronyms. So, you have IPF, NSIP, RBILD, DIP, COP and AIP. And we can further try to understand these based upon the presentation. So, if the presentation is acute, it is almost always an acute interstitial pneumonia. If it is subacute, it is typically an organizing pneumonia pattern. If the patient is an ever smoker, then we are dealing with RBILD or DIP. And if the patient has a longer history and we see evidence of a fibrosing ILD, then we are looking at either IPF or NSIP. And therefore, when we start interpreting our HRCT images, when we start looking at diffuse lung diseases in our minds, the first thing that we need to do is determine whether we are dealing with a fibrosing ILD or a non-fibrosing ILD. So, which are the fibrosing ILDs? We have the UIP pattern, which then includes the UIP without honeycombing and the possible UIP patterns, the NSIP pattern, the inconsistent with UIP pattern, chronic HP which goes hand in hand, and then the end stage of any insult. Everything else would be a non-fibrosing ILD. So, whether it's HP, DIP, sarcoid, cystic lung disease, edema, lymphangitis, AIP, organizing pneumonia, all of this basically become non-fibrosing ILDs. And today we will discuss all of these except cystic interstitial lung disease. Now, how do we diagnose a fibrosing ILD? These are the signs that we use: honeycombing, traction bronchiectasis, distortion of architecture, and intralobular interstitial thickening. And our aim is to, by using these signs and the way they present and the presence or absence of other things and the distribution, put the fibrosing ILD in one of these three buckets, and I will come back to this slide as we go along. Currently, based on the 2011 and 2013 criteria, the most important sign that allows us to pick up a fibrosing ILD is honeycombing. Honeycombing, as you see here, is the presence of layered cysts with shared walls stacked one upon the other from the pleura towards the hilum with a subpleural predominance or a subpleural distribution. You will find that there is no subpleural sparing, or the subpleural space is completely involved. Now, if this is so important, we need to be able to differentiate honeycombing from other conditions that present with cystic lesions in the lungs, and you will see them on the right hand side. So, on the left is honeycombing, on the right in this case are branching cystic areas that we get with bronchiectasis. In this situation, we have centrilobular lucencies without walls that we get with centrilobular emphysema, and here we have the presence of cysts with walls that are randomly distributed throughout the lung parenchyma, telling us that there is cystic interstitial lung disease, for example, the type we get with lymphangioliomyomatosis or Langerhans cell histiocytosis, etc. These four cystic conditions, honeycombing, bronchiectasis, centrilobular emphysema, and cystic interstitial lung disease, would account for more than 90 to 95% of all black hole diseases in the lungs. There is another way of looking at them: cysts with walls, cysts without walls. Cysts without walls would be centrilobular emphysema, cysts with walls would be honeycombing, bronchiectasis, and cystic interstitial lung disease. There are mimics as well, and we need to be a little surer of them. So, on the right here, we see traction bronchiectasis that almost looks like microcystic honeycombing, but you can trace these to the bronchioles, and these do not share walls, but we will talk more about traction bronchiectasis later. In smokers, as you can see here on the right, we have paraseptal emphysema. This will be a single layer typically seen in the upper lobes, and we should be able to differentiate this from honeycombing. And sometimes we just get cysts as a manifestation of a fibrotic healing process, in this case following a bout of organizing pneumonia. And these cysts will not have shared walls, they are not necessarily subpleural, they are not one upon the other, and we are able to differentiate this from honeycombing as well. Sagittal images help a lot, as you can see here. While on the axial images we do see typical honeycombing, the sagittal images allow us to confirm that diagnosis, to see deep into the recess, and to see that there is no subpleural sparing. So, once we have made the diagnosis of honeycombing, it allows us to confidently make a diagnosis of a usual interstitial pneumonia or UIP pattern. And the criteria that came out in 2011 and that still stand would mean having a reticular abnormality, honeycombing, and subpleural basal predominance with nothing else, no ground glass, no nodules whatsoever. So, you can see on the image on the right, we have honeycombing, subpleural basal predominance, and it is a reticular abnormality, and there is nothing else, no ground glass, no nodules, etc. That is our classic UIP pattern. And the moment we have this classic UIP pattern, if we don't have an obvious etiology, right? So, the patient doesn't have asbestosis, it's not familial, the patient is not a known connective tissue disease. If all of these so-called etiologies are absent, then we call it IPF, which is idiopathic pulmonary fibrosis, right? So, to call it IPF, we need to make sure it's idiopathic and that there is no underlying etiology. For example, this is a 27-year-old with a typical UIP pattern. We've got honeycombing in the lower lobes, right? But this patient has esophageal dilatation, this patient has scleroderma, therefore, this is not IPF, this is scleroderma related ILD. So, that's our first bucket, classic UIP, where we don't need to do a surgical lung biopsy. So, what is the problem? There are always problems in medicine, right? So, where is the problem now? The problem is, while CT is very specific, so if I see honeycombing, I see the UIP pattern, then we are very good, yeah, 99 times out of 100 we are going to be right. It is not very sensitive, and 2/3 of patients in different studies with IPF have other patterns or do not have the typical classic UIP pattern that we've talked about. So, what are all these other patterns that we need to be aware of if we want to make a diagnosis of IPF? The first is the UIP without honeycombing that Gruden and his colleagues have been describing since 2012, but you have the seminal paper that came out earlier this year. And what it has is traction bronchiectasis, which is our marker of a fibrosing ILD, because it stands to reason that if there is fibrosis, there will be traction bronchiectasis. Everything else that we have in a UIP pattern, the only thing missing is honeycombing. So, we have traction bronchiectasis, we have a reticular abnormality, subpleural basal predominance, and nothing else. There will be no ground glass, there will be no nodules, etc. And Gruden and his colleagues also added that it should be heterogeneous, which we would expect in IPF. There will always be some upper lobe involvement. Typically, that would be in the non-dependent anterior portion. So, you get the propeller sign on sagittal images, and it would be non-segmental and would cross fissures. But this is what you see with a classic UIP pattern as well. Here is a typical patient where we see traction bronchiectasis in the basal regions. We also have upper lobe involvement. This is heterogeneous, it's asymmetric, it's non-segmental, and this is our classic UIP without honeycombing pattern. And we add that to the bucket on the left, and we know that if we can make this diagnosis, again, a surgical lung biopsy is not indicated. But we then run into problems when we have to differentiate the possible UIP pattern from the NSIP pattern. Now, here we get a reticular abnormality, we get intralobular, interstitial and septal thickening, but there is no honeycombing and no significant traction bronchiectasis. Again, you won't have ground glass and nodules, and there is subpleural basal predominance, and this is what it looks like. So, on the right is classic UIP with honeycombing, but on the left we have a reticular abnormality, very subtle traction bronchiectasis, and that tells you it's a fibrosing ILD, but there is no honeycombing and no significant traction bronchiectasis. And the question is this possible UIP and therefore IPF, and therefore the patient would need treatment? Or is this an NSIP pattern that could either be lung dominant CTD or idiopathic, and how do we make the differentiation? CT criteria do help. NSIPs usually have lesser density and in the early stages more subpleural sparing, as we see on the left, and the possible UIP pattern may have more density, but that is not necessarily true. You can have fibrotic NSIP with higher density as well. Follow-up obviously helps. This is a patient in 2002 who we said is likely an idiopathic fibrotic NSIP. We weren't aware of the possible UIP term at that time, And by 2012, you can see that the patient has significantly progressed. There's significant fibrosis with traction bronchiectasis and non-dependent honeycombing, and now it's become a classic UIP pattern, and that was possible UIP therefore to begin with. Here's another patient in 2013 has what we at that time called an NSIP pattern, but in 2016 has developed frank honeycombing. So in retrospect, this was the possible UIP pattern. NSIP can regress, possible UIP doesn't. So this patient had in 2004 what we diagnosed as NSIP, did not have underlying connective tissue disease, and with treatment has regressed 2 years later, which would only happen with NSIP and not happen if this was IPF. And then some lesions don't change, as we see in this patient, and then we still wouldn't know, and if it's important, this patient would need a surgical lung biopsy. Age matters. If the patient is more than 70 years old, almost certainly this would be possible UIP unless the patient has underlying connective tissue disease. And if the patient is younger, less than 50, then this is likely to be an NSIP pattern, and we would aggressively look for an underlying etiology. But there will always be patients where differentiation is not possible. For example, we have a 57-year-old man who has a reticular abnormality in the lower lobes and in the upper lobes, no significant traction bronchiectasis or honeycombing, but it is a fibrosing ILD. And the question is this possible UIP and therefore IPF, or is this an NSIP pattern? The patient has no CTD, is a non-smoker, and this is the dilemma. So this is a patient who should go for surgical lung biopsy, which is what we did in this patient, and it turned out to be a possible UIP pattern, or rather it was a UIP pattern on histopath, and that basically meant this patient had IPF. And so that's our middle bucket. We have reticular opacities, we have no significant traction bronchiectasis or honeycombing, it is basal predominant and no other findings. And we need to diagnose possible UIP as against an NSIP pattern, because both of them pretty much look the same. And if you are not able to make out the difference, then a surgical lung biopsy typically becomes required. We then come to the third bucket, and that is the inconsistent with UIP bucket, where we get a reticular abnormality. We get honeycombing and traction bronchiectasis, but this is not necessarily subpleural, it is not necessarily basal, and we get other findings such as ground glass, nodules, etc. And this is the same pattern that has been described with chronic fibrotic hypersensitivity pneumonitis as well, and these are all the findings you get with chronic HP. So chronic HP and the inconsistent with UIP pattern seem to overlap with each other. And we have a patient here on the left has typical ill-defined bronchocentric nodules that we would get with hypersensitivity pneumonitis, which is what she had. It was poorly treated with non-compliance, and then on the right you can see that this has progressed over 5 years to a chronic HP situation with traction bronchiectasis, distortion of architecture, etc. These patients have differing statistical data at this point in time. So if you look at Morel's paper from Spain, they thought that even patients who have classic IPF, if they were managed or investigated aggressively, were subsequently proven to have chronic HP in their center. If you look at Yagihashi's recent paper, where he looked at the data from the earlier studies, he found that 95% of patients who had a so-called inconsistent with UIP pattern had IPF on histopathology, but then this is a highly selective group, but as was the group in Morel's papers. So these patients who have an inconsistent with UIP pattern may have IPF or may have chronic HP, and while there is dilemma in data, when it comes to patients in real life, we really need to then use our clinical judgment to be able to differentiate between them, and sometimes if we can't, these patients may also require either bronchoscopy and lavage or surgical lung biopsy. If we take the Jaipur registry data into account, that says that almost 45 to 48% of patients with ILD in India have HP, then our index of suspicion for chronic HP in those patients who have an inconsistent with UIP pattern should be kept high. So now you can look at the bucket on the right where we have reticular opacities with traction bronchiectasis, honeycombing, etc., but we have other findings. We have these may not be subpleural, they may not be basal, there is often ground glass, there may be bronchocentric nodules, etc., in which case this could be IPF, but it could also be chronic HP. This may require a surgical lung biopsy, and of course the clinical history and BAL examination may also become relevant. Why is all of this important, and why have I spent so much time talking about the fibrosing ILDs? If you look at the scenario maybe 10 years ago and back, the overall prognosis of a patient with IPF was so bad. Today we have pirfenidone, we have nintedanib, drugs that allow us to manage patients with IPF better, and therefore it has become imperative that we can accurately make a diagnosis of IPF and or accurately rule out the presence of IPF. So if the patient has IPF, we know that there are drugs we can give. If the patient doesn't have IPF, then we would not give drugs, and therefore it becomes even more important than ever before to be able to be accurate, or to say that I don't know, therefore the patient requires a surgical lung biopsy. So let's summarize. If we have a typical UIP pattern with honeycombing, then that suggests IPF with high specificity. That would mean honeycombing, basal predominance, and nothing else. With the understanding that 2/3 of patients have other patterns. These other patterns include the UIP without honeycombing pattern, but where there is traction bronchiectasis, and the possible UIP pattern that simulates an NSIP pattern and often requires a surgical lung biopsy, especially in the younger people, and the inconsistent with UIP pattern, where we also have to deal with the equally possible chance of chronic HP, or perhaps a larger incidence of chronic HP. We then move on to the non-fibrosing ILDs, where typically we see septal thickening, ground glass and consolidation, and nodules, and as I said today, we will not be talking about the cystic ILDs. Ground glass is defined as the presence of increased opacity in the lungs that does not obscure the underlying vessels. It usually involves the lungs patchily and creates what looks like a mosaic pattern, though we try not to use the term because then it gets confused with the mosaic attenuation that we get in chronic pulmonary thromboembolism. If we get only ground glass with nothing else, then the diagnosis is entirely dependent upon the clinical presentation. So the same pattern that we see on the right, if the patient is a non-smoker, if it is of subacute onset and there is a history of exposure to pigeons, we would call it hypersensitivity pneumonitis. The same pattern in a smoker would be called desquamative interstitial pneumonitis, or if the lesions are less severe, perhaps respiratory bronchiolitis ILD. If the patient presents acutely within 24 to 48 hours, the same pattern that gets called acute interstitial pneumonia. And if the patient is HIV positive or immunocompromised, the same pattern would be called pneumocystis carinii pneumonia, or Jirovecii, so PJP or PCP. Of course, we need to differentiate ground glass from small airways disease and chronic pulmonary thromboembolism that we do with the help of expiratory images. If you see the inspiratory image on the top, basically we are seeing areas of increased lucency with some increased density at the periphery. These white areas show a gradient and become whiter on the expiratory images, telling us that this is normal lung, and the black areas become blacker, telling us there is air trapping. So this is small airways disease, and in chronic pulmonary thromboembolism, the black and the white areas will not change significantly. And because the white areas represent hyperperfused lung, we see fat vessels there, we will see MPA dilatation, and it should generally be possible to make that differentiation. Now, ground glass may also occur in conjunction with other signs. So, we saw ground glass that was de novo and where we could only make the diagnosis based upon the clinical presentation. But what if ground glass presents with consolidation? And we know that consolidation is increased opacity that obscures the vessels and where we see air bronchograms, as you see on the right, compared to the ground glass on the left. Now, here we have a patient who has perivascular areas of consolidation and ground glass together. Here is another patient who has more consolidation with a lower lobe predominance, but with some ground glass at the periphery. Here is a patient with a reverse ground glass appearance where there is ground glass at the center and the arrow points to the consolidation at the periphery. And here we have bilateral peripheral lesions like a reverse bat's wings with ground glass in the center and consolidation at the periphery. All of these patterns are typical of an organizing pneumonia pattern. We call it cryptogenic. Like with idiopathic pulmonary fibrosis, we call it cryptogenic only when there is no underlying etiology. So, remember that organizing pneumonia patterns can occur with drugs, a bunch of chemotherapeutic drugs, with toxic fume inhalation, environmental exposures, connective tissue diseases, etc. And so, if there is an etiology that explains the organizing pneumonia pattern, then it is that etiology OP pattern or organizing pneumonia pattern, but if we do not find an etiology, then this is cryptogenic organizing pneumonia. The history matters. Patients who have an OP pattern typically present with a 3 to 4 weeks history of dyspnea, often with fever, velcro rals, and are desaturating. Let us see this patient who has similar bronchocentric areas of consolidation and ground glass, but is a 65-year-old man with hemoptysis without dyspnea. This is not an organizing pneumonia pattern clinically. This is a pattern that we would get with invasive mucinous adenocarcinoma, earlier popularly called bronchoalveolar carcinoma. Similarly, this is another lady with hemoptysis, no history suggestive of an organizing pneumonia pattern, focal, single segment, and again invasive mucinous adenocarcinoma. Similar patterns may occur with other conditions. So, again we have peribronchovascular opacities, typically a combination of ground glass and consolidation. In this case, we biopsied this and it was proven to be IgG4 disease. And on the left here, you see widespread consolidation and ground glass again that has regressed after treatment, and this is what you can get with small vessel disease or vasculitis. In this case, this was Wegener's granulomatosis. So, when we see a combination of ground glass and consolidation, the commonest etiology, if we have the typical clinical presentation, would be an organizing pneumonia pattern, with the understanding that IgG4 disease and vasculitis can also behave in the same manner, and we do need to rule out vasculitis in almost all of these patients, and that similar patterns may occur in invasive mucinous adenocarcinoma or lymphoma, and obviously the clinical presentation is very important as well. If the ground glass occurs with fibrosis, we have already seen this is typical of chronic HP, and we can see that here on the left we have ill-defined bronchocentric nodules with a little bit of fibrosis in the non-dependent right middle lobe anteriorly, and on the right image we can see a lot of fibrosis with traction bronchiectasis and their interspersed areas of ground glass attenuation. Here is a patient who in the upper lobes has ground glass with bronchocentric nodules, and this is HP, whereas on the right you have started seeing fibrosis on the prone images in the basal regions. Then we can have ground glass with septal thickening. So, here is a patient whose predominant pathology is ground glass, and then you have these interspersed areas of septal thickening. This gives rise to what we call a crazy paving pattern, and this is commonly seen with alveolar proteinosis. And again, alveolar proteinosis can be primary or secondary as well. Here is another slightly unusual and rare condition where we have a combination of ground glass and septal thickening that we see on the right. But this patient has diffuse subpleural ossification that is going into the interstitium, and you can see that along the bronchovascular bundles, and this is what is classically seen with alveolar microlithiasis. Now, what if there was pure septal thickening without the ground glass? So, here is a patient who has bilateral pleural effusions, presented acutely with dyspnea, the septal thickening which is smooth in the upper lobes as well as in the lower lobes, and some hint of perihilar ground glass. This is what we typically get with pulmonary edema, usually due to left-sided dysfunction. And this patient came back after diuretic therapy 48 hours later, and you can see that everything has regressed. The septal thickening is gone, the subtle ground glass is gone, and the bilateral pleural effusions have gone as well. This is a patient with mediastinal fibrosis. On the right we see a mass that is occluding the right inferior pulmonary vein, and because of the venous occlusion we have venous congestion in the right lower lobe where we see septal thickening outlined by the white arrow, and this is another cause of segmental or lobar septal thickening when there is a pathology of the draining vein. This is a patient who has a mass in the right upper lobe, and then there is septal thickening seen in the rest of the lobe. This septal thickening is characteristic of lymphangitis carcinomatosis, and you see that with a primary in the lung itself. Please remember not to make a diagnosis of lymphangitis in the absence of a known primary. To see lymphangitis presenting as an unknown primary is extremely rare, and you probably see one case in your entire life in practice, and therefore it's just much better to look for other etiologies. So, if we see pure septal thickening, we are looking at pulmonary edema, we are looking at pulmonary venous congestion, and we are looking at lymphangitis carcinomatosis. We then move on to nodules, and we have already been seeing these ill-defined bronchocentric nodules on multiple previous scans. When we see them, if the patient is a non-smoker, it is hypersensitivity pneumonitis. If the patient is a smoker, it could still be HP, but then we start thinking of desquamative interstitial pneumonitis. Now, in a smoker, if we get less dense, subtle peripheral ill-defined bronchocentric nodules as we see on the coronal image on the right, then we would say this is respiratory bronchiolitis. And when the respiratory bronchiolitis is associated with some fibrosis, either traction bronchiectasis or a little bit of peripheral honeycombing and reticular opacities, then we would call this respiratory bronchiolitis ILD or RB ILD. However, if we have discrete well-defined nodules, then we are looking at an entirely different set of pathologies. And here we see a patient who, when we blow up the image, has discrete perivascular nodules. There are also discrete septal and subpleural nodules, and this is a pattern that is classic of sarcoidosis. In patients with sarcoidosis, or sarcoid for short, we see subpleural nodules very well along the fissures on coronal images. So, here you can see perihilar nodules on the axial image, and the coronal image clearly shows the fissural nodules really well. Sarcoid nodules in the lungs start in the perihilar region as a rule, and here you can see a patient where one of the vessels shows perivascular beading, and we have marked that with the red arrow, and the rest of the nodules are arranged around the right hilum. If you see carefully, even on the left in the infrahilar region around the pulmonary artery, we can see some nodules. Like with chronic HP, sarcoid that is not treated well or does not respond to treatment can then undergo end-stage fibrosis, and it will look like the inconsistent with UIP pattern with band-like areas, some ground glass, traction bronchiectasis, not subpleural, not basal, and that is not as common as chronic HP, but also a diagnosis that you would have to make. Let us look at other findings in sarcoid, because sarcoid is a great mimic and it is not uncommon. So, here is a patient who has typical subcarinal bilateral hilar non-necrotic lymphadenopathy and has a focal lesion in the lung with reverse ground glass, but the periphery where we see consolidation is nodular. So when we see nodular consolidation as part of a reverse ground glass halo, that should alert us to granulomatous disease. In this case, this was proven to be sarcoid. Sarcoid can also present with larger perivascular opacities like we get with vasculitis, IgG4 disease, etc. And again, we would need to prove the diagnosis to then confirm what's happening. We can see the different stages of sarcoid. So here's stage 1 where we have non-necrotic lymphadenopathy in February with normal lungs. And while the lymph nodes have regressed in September, we now see typical perihilar, fissural, subpleural nodularity that is so classic of lung involvement. What are the other nodular diseases that we need to be aware of? And that would be differentials. This is one, 2 to 3 millimeter size nodules randomly distributed throughout the lung parenchyma. This is very typical of miliary disease. Here we have high density, discrete but confluent bronchocentric nodules that have for so many years been labeled as tree and bud appearance, and this is called infectious bronchiolitis and commonly seen in tuberculosis. And here we have another condition that again is common in the areas where it occurs endemically, where we have nodules of varying sizes but they are discrete, as you see on the lung windows. Then we have an area of massive fibrosis in the left lung, and we have eggshell calcification within the lymph node. So this suggests silicosis and typically would occur in patients who have exposure to silica, usually within the coal mines. Do remember that eggshell calcification should alert us to the possibility of silicosis, and while it can occur in many other conditions including treated sarcoid, treated TB, treated lymphoma, etc., the commonest entity that presents with eggshell calcification remains silicosis. So we can put that in a chart. If we have ill-defined nodules that are diffuse, that's typically HP. Rarely you would get it with DIP or as a manifestation of giant cell interstitial pneumonitis with hard metal exposure. If they are discrete nodules, if they are perihilar, subpleural, fissural, then that's sarcoid. If they are small 2 to 3 millimeter size, then that's what we get with miliary, clustered focal centrilobular tuberculosis. And if they are random, confluent, different sizes with exposure to silica, then that's what we get with silicosis. So in the last few minutes, we've looked at the role of lung CT or HRCT lung in the diagnosis of diffuse lung diseases. We know that we need high quality scans, and then looking at the different patterns, we should be able to arrive at some diagnosis. The idea is to differentiate fibrosing from non-fibrosing, and that is done by looking at honeycombing, traction bronchiectasis and reticular opacities if present. That would imply a fibrosing ILD, and then we try and put them in those 3 buckets. The first bucket is classic UIP and UIP without honeycombing, where you don't need to do a biopsy. The second bucket is the possible UIP pattern that simulates an NSIP pattern where often a biopsy is required, and the third bucket is the inconsistent with UIP pattern that overlaps with chronic HP and where sometimes a biopsy is required, but a good clinical history with BAL may also help. The non-fibrosing ILDs present with ground glass, or as we use the term ground glass plus, where it's ground glass with consolidation, ground glass with septal thickening, ground glass with fibrosis. Or then we have septal thickening itself without other findings. Then we have nodules, or predominantly nodular diseases that are either ill-defined or well-defined. And then with all of this understanding coupled with the clinical presentation, we can often make one diagnosis or give a short differential in most instances. And then obviously those patients that require a biopsy, we should be then able to have a biopsy correlation that allows us to get even better at making the definitive diagnosis. So this was the role of HRCT in ILDs. Thank you for your attention.